Today I'll discuss a patient who presented with knee pain that was acute from a fall on ice about 3 days before the patient presented to my office. The pain was local to the knee only on the inside and outside of the knee, so both sides of the kneecap. The pain was improving, but she was still quite limited in her daily functions, especially with weight bearing. She had adopted using a cane and a brace to help with the pain and was avoiding things that were very triggering. So in the physical exam, the pain was local on outside and inside of the knee. She had no loss of flexion, but she had mild loss of knee extension with pain during the movement into extension and an end range. When I did ligamentous tests of the 4 main ligaments of the knee, they were normal. There was mild swelling. There was decreased patellar mobility because of that likely. Straight leg raise was normal. Hamstring testing and quadriceps testing, muscle testing, and seated was 5 out of 5 without pain. So we're not thinking muscular, we're not thinking ligamentous. I didn't do meniscal tests or other special tests. I didn't think those were necessary, but I did want to rule out in my head eventually if this was a joint derangement that would respond specifically to one movement repeatedly or not. So what I decided on day 1 is not to go through repeated movement testing, but to instead kind of classify this or diagnose this, if you will, as kind of a post-trauma to the knee where there was no major structural instability or lesion, but there was a lot of trauma and swelling to the knee, and it was still only several days old. So my goal for her over the next few days at home was to try to restore the knee extension that was missing. So her homework became lying in supine, propping her heel up on 1 to 2 inches of something steady like a book, and just letting it passively relax into end range extension for a few minutes. About 4 times a day is what I instructed her to do. I wanted her to increase her activity as able, not really letting that pain in the knee get above a 3 out of 10. So we wanted to keep it mild and not exacerbate things or kind of re-traumatize or re-aggravate the structures in the knee that were traumatized from that twist and fall. And if the brace and the cane still provided support and were helpful, continue to use them, but ultimately we talked about, reducing those as needed. So a lot of her home program for now was discussing what I found, how I think this has just had a trauma. It will get better. We're going to try to restore extension, and we want to get back to life in a, expedited fashion, but with caution. We don't want to do too much too soon and re-aggravate those structures in the knee that were impacted by the fall. So I saw her about 2 weeks, almost 2 weeks later. She said she was much improved, but she still had problems, for example, rising from the floor with knee pain. Her walking and sleeping pain had improved, but then it got worse, possibly due to increased activity. She wasn't quite sure. She noticed a popping now on the inside of the knee. The pain was now just on the inside of the knee. At the time of the visit, it was about 3 to 4 out of 10. And so no longer pain on the outside, just on the inside, kind of anteromedial knee pain. The popping was new. She was concerned about the popping. I looked to see if she was able to do the home exercise program of supine knee extension correctly, and she was. So when we got to the physical exam, flexion was still good of the knee. Extension was now full, but there was end range pain. A mini squat was okay. Single leg balance was okay. There didn't seem to be any major proprioceptive deficits. Walking in the hallway was a 1 or 2 out of pain with some popping. So I decided it would probably be helpful to look to see if there was a specific movement that would underrange this joint, if that's what the actual problem was. I looked at supine repeated flexion. That had no effect. I looked at standing repeated flexion of the knee. That had no effect. I looked at seated repeated extension. That would produce some pain during the movement, but not remain worse afterwards, but had no effect on the walking and popping, which is what we use as the major baseline to assess for cause and effect. And I also, for number 4, I looked at supine sustained extension, kind of similar to what we'd done in the past. And it produced pain, didn't make it worse, but maybe a little bit worse. So I didn't want to go there. So It didn't look like this was a joint derangement, because what we're thinking of for a diagnosis of a joint derangement or a mechanical problem in a joint, whether in the spine or an extremity joint, is that moving in a specific direction repeatedly will have a rather rapid impact on the baselines. So for someone like her, where there is still a motion loss or a pain with motion, I would expect to see some change. If we do 20, 30 repeated extensions of the knee, I would expect to see some change if that's the right direction. Vice versa, if we do repeated flexion and that's the correct motion for this knee, I would expect some change. So like I said, I looked at 4 different things, probably doing 20, 30, or possibly 40 reps. I didn't write down the numbers, but we can look at it in supine, seated, standing, semi-loaded, loaded. There's lots of different variations on flexion and extension of the knee. There's also rotational movements of the knee. There's also traction. There are many different types of repeated movement tests I will use for the knee, but looking at these 4, I didn't see anything stand out at me. Nothing was telling me that this was a mechanical derangement that needed a specific movement. It was still telling me in the patient's presentation that this was post-trauma and that it would heal naturally. We just need to be cautious with adding more activity and try to restore motion in an effective way. So what I gave her for homework was 3 times a day, I'd like you to take it to end range flexion and end range extension. Again, just kind of letting the patient get some more confidence with movement, getting movement through the knee so the person's not just sitting there or lying there working all day and not moving it as much. And then of course, education again on reducing the cane, reducing the brace as able, getting back to former exercise routines. We talked about, doing a little bit of walking or doing a little bit of certain weight-bearing strength exercises. Visit 3 was about a month later. She said the inner knee was still a little bit painful. The popping was a lot better. The pain could fluctuate a little bit. Sometimes she did notice that she lost extension of the knee, but she was overall much better and was able to do the homework. And her range of motion testing and the physical exam, flexion was still good. Extension, a little bit limited this time with some pain. I decided I would quickly look at her low back just to see if there's any involvement there, because obviously when someone falls, not only are they affecting the knee, but all the other joints are likely involved in the trauma of the fall. So I just did a quick movement testing of the low back. Just check out those 4 movements of the low back. I found a minimal to nil loss in many of the 3 of the 4 planes. And then I looked at, if doing some low back extension in prone had any effect on the knee, specifically with walking, which was the baseline we used again. No effect. So I abandoned that line of investigation, but I just wanted to quickly see, again, for a patient like this, I would expect that if it were back related and we did 10 prone lumbar extensions, I would see some effect on the walking, because joint derangements in this type of patient population where it's acute should change quite quickly if there's a correct motion. So I decided I wanted to make sure I still wasn't missing any repeated movements. So I looked at extension with tibial rotation. I looked at a few different versions of extension and flexion that we hadn't looked at the last visit. We looked at 4 repeated movement tests last visit. This time we looked at 5 or 6. And, it seemed like flexion with the foot on the chair, so semi-loaded knee flexion, produced some improvements with the walking. So I decided to change her home program to look at flexion with the foot on the chair instead of supine, and also continue with increasing activity, less babying of the knee, hopefully getting back to normal as quickly as possible within a few weeks. And, I gave her the home program of flexion with the foot on the chair times 10 every couple hours. So I increased the frequency with looking just at flexion. And then through email a few weeks later, she said she was totally fine. So in my mind, I'm classifying this as post-trauma. It didn't seem mechanical in nature. It didn't seem structural in nature. Of course, there was some inflammation at the beginning that she was already mediating with over-the-counter medicines and then elevating and ice. Like I mentioned, she'd kind of adopted the RICE protocol on her own. There was inflammation at the beginning. You could see some swelling of the knee joint, but I don't think this was predominantly inflammatory after that first week. So I would call it post-trauma. And for people where it's post-trauma, what we're really trying to do is rule out if it's something else, right? When you had this acute traumatic event to the knee, Did something structurally become deranged? Did something mechanically become deranged? Did you set off an inflammatory process that's now taking over and becoming a nuisance and becoming part of the actual pathology? And when we rule those things kind of out, muscle tear, meniscal tear, ligamentous tear, fracture, etc., then we can say, okay, it's not one of those things. It seems like it was just traumatic. It was traumatized. A number of tissues were impacted kind of globally around the knee, and we want to get you back to activity, get you back to having confidence in this knee, get you back to having full range of motion. Strength was not impacted, so that was not something we were looking to address. And that's how I assessed this person and how I treated her with these 3 visits over these about 6 weeks. So, it's different than a mechanical joint derangement, but it is a presentation you'll see sometimes. And again, for me, the key is ruling out something else. And if it's not something else and it just seems like post-trauma, let's get this person back to life as soon as possible and restoring any impairments that may be present.